Okay, we're recording, so thank you.
Okay, let me just get this up. Sorry guys.
Are you having trouble sharing your screen?
Yes, hold on. Jamie, I emailed you my presentation just in the matter of time. Would you be able to pull it up for me, please?
You just sent it to me?
Yes.
I don't have it here. Let's see. It's not letting you share your screen?
Let me see something. Hold on.
You've been given permission to share your screen.
Okay.
Folks, we apologize for the technical difficulties here. Whenever technology is involved, there's always an issue, it seems.
I don't think it's picking up my screen.
You don't see your screen on the options? No. Don't
Share. Okay, wait. Okay.
Got it. Got it. Yep. What's happening? There we go.
Okay. Good afternoon, everybody. My name is Cinnamon. Oh, you can hear me now?
Yes, we can. Thank you.
Okay, perfect. Sorry about the delay, guys. Good afternoon. My name is Cinnamon Tucker. I have been a nurse practitioner and a nurse in the palliative medicine world for a while. Let me say my disclaimers are by no means I'm an expert. I am just out here learning as much as I can to help our patients. I'm in the New Orleans area at UMC, as Jamie said, and I thank you to the Palliative Medicine Committee for inviting me to speak with you guys today. Please feel free. I want this to be open and discussion. If you have any questions, chime in, and I appreciate your feedback. And I know everybody does something a little bit different in the different parts of their communities and for their patients. So whatever we can share with each other to help our patients will be greatly appreciated. Morphine, Dilaudid, methadone, oh my. I know in our practice here in the hospital, is very different than the community-based setting, but as we are getting more patients, younger patients, and who are having more complex symptom management, we're having to broaden our scope in how we use medicines and what we actually use to optimize comfort, but also maintaining patients' functional status. Objectives for this presentation: the nurse practitioner will feel more comfortable and confident in treating pain and other symptoms common in hospice and palliative care patients. The MP will be able to accurately identify different types of pain, selecting opioids and adjuvants for pain, including methadone, and managing pain with substance use disorder. Also, other common conditions, insomnia, depression, constipation, cachexia. Recommendations for further learning. I always want to make sure as a provider, we can never know everything and things are changing all the time. So I do encourage certification for hospice and palliative nurse practitioners, even for our nurses and our CNAs. I've been certified for a very long time. And I remember after being early on in my career, after being in the hospice world for a while, just the huge gap of knowledge that I felt like for me, that going from being non-certified to certified, it was huge. And I never forget, I can't even remember, Robin may remember, umpteen years ago, Oshner used to put on this, the hospice and palliative care nurse certification course, and it was phenomenal. And just after going through that course and sitting for certification exam, I felt like I was so much better prepared to take care of my patients. So I'm always a huge proponent of certification, even for all members of our interdisciplinary team. Also, AAHPN is a great resource for education. I know some of my colleagues here attended this year in Arizona. And so that was great to see. And also LNAC certification. And I think LMHPCO is actually looking into providing some level of courses. So be on the lookout for that in the future. Case study number one. I love case studies. I don't know about you guys, but let's start off with this one. And please feel free to unmute and let me know your thoughts, but I'll read it. Miss FJ is a 50-year-old female, double type, with past medical history of end-stage renal disease, bacteremia with incomplete treatment, xanthogranulomatosis pyelonephritis, and a history of nephrostomy tubes, hypertension, hyperlipidemia, who presented with a recurrent continuation of previous pyelonephritis and volume overload after missing dialysis. Of course, she was having intractable pain, and she only speaks English. So guys, this is a real life patient who I had this week, and so welcome to my world. When I was consulted, she had received 19 milligrams of IV Dilaudid in the past 24 hours. Those are her vitals, as you can see. Pain is 10 out of 10. Intractable vomiting, GFR is 10, BUN 45, creatinine 6.58. Those orders below were actually written from the internal medicine team when I picked her up. And there you can see her assessment. Let's talk about, if people feel free to unmute, what would be your impression of this patient and what would you do to help treat her symptoms? So you guys unmute and let me know what you, let me know your thoughts. I can't see the screen to unmute, but if Jamie, you can unmute, or people can feel free to
Hey,
unmute.
hey, this is Kalisa from Tupelo, Mississippi. How are y'all?
Good. What do
Good.
you think?
Well, when I'm looking at it, I see she's got some kidney issues. So definitely the Dilaudid, in my opinion, would not be a horrible medication for her. However, she's consuming or taking a lot of it, and it does not look like she has anything really for long-acting pain control.
Absolutely, absolutely. Anybody else?
This is Robin. I agree. I think Dilaudid is a good choice. I'm thinking even oral form may be better because it would last longer than the IV dosing would, and maybe also considering something for long acting as well.
Absolutely, absolutely. I find here in our practice, I'm always a little bit concerned when IV doses, especially high dose IV medications, are given, and then looking at her renal function as well. Was also concerned. I didn't add any other. She wasn't on any adjuvants whatsoever. And she had left the hospital a couple of times previously, because she wasn't getting adequate pain management, and also the language barrier. So let's move on. Palliative medicine introduced to patient via translator, comprehensive pain assessment performed. Patient rates mixed type pain is 10 out of 10 on IV scheduled on Dilaudid 19 milligrams given over the past 24 hours. Also with intractable nausea, which patient is getting Zofran frequently. Upon exam, she's awake Irritability times 4, conversive. Pain is better each day, I guess so, with 19 milligrams of morphine. Points to flank area with anasarcal, bilateral +3 edema, not eating well due to pain and nausea. Patient seems to have limited insight into health management. We'll further discuss and schedule patient with palliative outpatient provider for chronic pain with life-limiting illness. Patient's last bowel movement was today, minimal PO intake. Did take some sips of water and jello without nausea. Expressed concern to patient about leaving hospital prior to discharge. She agreed to remain inpatient until safe discharge and follow-up arranged. And so this is kind of what I started for her. She is unfunded, so we did apply for coverage for her medication. What are your thoughts about this plan? What would you do different?
I might have started on a slightly higher fentanyl dose, but it's not a terrible place to start. I've just never had a lot of success with a low dose like that if someone's required a lot of medicine.
Yeah. So in the interim, which I didn't include in this part, she was started on dialysis. They removed approximately about 4 liters one day, and I think like 3.5 liters the next day. So she was, so a lot of fluid was taken off. A lot of the edema went down. She did well with the fentanyl and the PO oxycodone, even able to wean some of that back. Stopped scheduled Dilaudid, did leave her on some IV just until the fentanyl could kick in, and then gave her something for a bowel regimen. Okay, so
I'm sorry.
Go ahead.
I was just gonna say I may have even started her on like some Zofran scheduled until we could kind of get on top of her nausea. That may have helped some as far as that symptom, but
Absolutely. And we'll talk about that. Actually, I put her on some scheduled. She was getting some Zofran via IV pretty regularly. I did an EKG, and her QTC was in normal limits. And I started on some Zyprexa IV and then transitioned to PO, and the nausea was able to come down. I was really thinking that because of the amount of fluid that she had, and then underlying pain, and also some anxiety about treatment, and nephrology was going back and forth about whether or not she should start on dialysis. She wasn't a fan of actually starting on dialysis, and especially because it was being unfunded, we weren't able to provide her for a dialysis chair. Just added a lot of extra distress to her as well. So absolutely, some Dilaudid was a great option. I use a lot of Zyprexa in my practice, and to help with nausea and pain, and also some anxiety. And we'll talk about that a little bit later on as well. Okay, what is pain? An unpleasant sensory and emotional experience associated or resembling that associated with actual or potential tissue damage. And that's coming from the International Pain People. Pain is always a personal experience that is influenced by varying degrees of biological, psychological, and social factors. Pain and nociception are different phenomena. Pain can be inferred solely from activity in sensory neurons. Through their life experiences, individuals learn the concept of pain. And that was pretty, I'll step aside to kind of talk about that. People perceive pain differently. You can have two people with a broken arm and their responses to pain will be vastly different. Pain also, as we know, varies by people's ethnicity and their experience of untreated pain. So all of those are factors that are taken into account as well. A person's report of experiences pain should be respected. And we are doing better at that now, understanding whatever the person says their pain is, we're honoring what their pain level is. Although pain usually serves as an adaptive role, it may have an adverse effects on function and social and psychological well-being. We know that if you're in pain, you're not going to eat, you're not going to move, you're not going to be as active and engaged, and then kind of the spiral starts to happen. I see a lot of time in our patient population, a lot of untreated pain, and which causes some people, especially if they don't have insurance coverage for pain management, and that they start to use illicit substances, or buying Percocet off the street, or buying gabapentin off the street. And then a whole spiral starts to happen because of that. And then we have verbal description is one of several behaviors to express pain. Inability to communicate does not negate the possibility that a human or a non-human animal experiences pain. I struggle with this in even if a patient can't talk, or they have some expressive aphasia, we still need to be able to accurately treat someone's pain. And even people that are nonverbal, or they may be at end-stage dying process, we still need to treat pain appropriately, often looking at vital signs and other things. I had a patient recently who underwent surgery for spinal cord compression, and he laid very still. He did not move at all. And I was speaking to the nurse about how he had been doing over the past couple of hours. And she's like, "Oh, he's fine. He doesn't move." And I said, "Well, that's a problem, because we want him to move, and we want him to be comfortable enough to be able to move, especially after spine surgery. I don't need him to lay in bed like a sick man. I want him to be able to, his pain to be managed enough that he can participate with PT and OT." I actually took a picture of this at my house. Do you sometimes feel like you're throwing spaghetti at the wall and hope that it sticks, or hope that things work? You know, everybody responds differently. But I do sometimes feel like, geez, I'm making the best decision for my patient. I hope this works, but making sure to evaluate the patient and thereafter intervention. All right, and so then we have the famous WHO pain ladder from 1986, and then the modified pain ladder. And then modified pain ladder that was adapted in 1996. So kind of like now-ish, but we see that things have changed going from 86 to 96. This is bidirectional so that we can titrate up or titrate down. And also we see in step 4 the including of other interventional pain management options that we have for treating pain. I did, while I was doing some research for this presentation, I have seen a lot of conversation in the literature about the WHO pain ladder not being appropriate for patients with non-malignant pain. Initially, it was created to treat cancer-related pain. So there are a lot of discussions out there about whether or not we should be using the same methods for non-cancerous chronic pain. All right, let's talk about some major opioids. I kind of picked the big 5 that we commonly see in practice. I don't, and let me say this, I don't use ketamine. I know other agencies or practices are using ketamine. If you are using ketamine in your practice, please, I would please chime in and let me know how that's been. But I don't use it at all, so I didn't feel it was appropriate for me to discuss that. But that is an option, and a lot of
Cinnamon, are you guys using buprenorphine?
We aren't in our palliative practice. I oftentimes, if there is patients with comorbid substance use disorder, we manage those patients with our addiction psychiatry department. Do you guys use that in your practice at the VA?
We have occasionally, I wouldn't say it's a lot, but I think we're going to probably start using it a lot more. I went to a few talks on it at the conference last week, and I think we're going to see it a lot more in the palliative care realm, particularly for those with a history of opioid use disorder.
Absolutely. I don't know about other practices, but here I want to say greater than 30% of the patients that we serve in our practice have some level of substance use disorder. So I agree, Robin, wholeheartedly. It's something that we may have to all start learning and exploring to better meet the needs of our patients. Well,
And
sir,
just a comment too. I totally agree, Cinnamon and Robin. You know, it's kind of exploding right now, and it does take a little bit of attention to get comfortable with how to use it. It sounds like y'all are really fortunate to have a psychiatry, substance abuse psychiatrist that's participating in their care. We have one here too that helps us with buprenorphine, but it's definitely over this last year become something that we are all becoming a little bit more comfortable.
We have that support here too at the VA, so which is a beautiful thing because we certainly reach out to them.
Yeah, and Robin, I didn't see you at the conference. I'm sorry about that.
Oh, you were there? I didn't see.
Yes.
I'm sorry, I didn't see you either.
I think definitely, I will say, prior to coming into the hospital setting in palliative medicine, I never initiated methadone. Would always, if I inherited a patient with methadone, I would continue. But up until recent, and did I start initiating methadone just because I wasn't comfortable with it. And so I think that's one of the things that buprenorphine and ketamine are one of the things that we should be educating ourselves, because we're going to start receiving patients that would need management. And now there's been some, especially for nurse practitioner, some edging in the advancement of our licensure that to cover those patients. But for the outpatient palliative providers, are y'all using buprenorphine, or what do you use for your patients who are coming to you with buprenorphine?
If they're coming with buprenorphine, we continue it. Is that what you mean?
Outpatient, we prescribe it in the outpatient setting.
I don't know,
So do we.
probably most people are multitasking in the middle of the day. But definitely that is on the horizon for us in palliative medicine. I did also read in some of the literature that some palliative inpatient units are using ketamine infusions for palliative sedation. I don't use that, like I said, inpatient for palliative sedation. Occasionally for my hospice patients at home that need palliative sedation. Usually I am using either morphine or Dilaudid via IV, or I use phenobarb occasionally. I can tell you it doesn't happen a whole lot, but there have been instances that I've had to use it. Just kind of looking at this, just to kind of put it all on one slide. We have morphine, fentanyl, Dilaudid, and oxycodone, and just the conversions. I know there are a lot of different conversion factors that people use. Just when I was educated on doing my conversions, this is generally what I use. So we have, starting on the far right-hand side of the screen, PO to IV morphine is 1 to 3, duration is 3 to 5 hours. Morphine is pretty inexpensive. It comes in a variety of preparations. And then we have oral dosing. We usually start very low. It can be dosed every 4 hours. We have sustained release, which can be given oral or rectally or intravaginally. And then we have IV and PCA. Again, we want to watch out for those patients in liver or renal failure. Next, fentanyl, IV or transdermal. We use IV fentanyl in our ICUs. We don't use it on the floors here at the hospital. We do use a lot of fentanyl patches here. Duration for the IV, 4 to 6 hours, transdermal, 48 to 72 hours, depending on patient experience. It's a little bit more pricey. I know it's generally covered for our home patients on their formularies, and it can be given IV by patch or by lozenge. Lozenges are usually not covered under a lot of hospices formulary. And usually you have to have pretty Cadillac insurance to get it covered. Maybe I've had 3 patients in the last couple of years that were able to get it covered. Starting dose usually 12 to 25 micrograms. I have the PCA doses. We also want to watch fentanyl for our liver patients, our low BMI patients. Short-term use, we don't want to use it, and for head injuries. I will say I often use fentanyl a lot if patients are have difficulty communicating, or they're the kind of patient who doesn't want to ask for whatever reason, or I'm worried about diversion issues. Oftentimes, for patients that have issues, I will send them, they'll get a patch at a time, and they'll just have to come into the pharmacy to get 1 patch at a time. We have had some issues with patients with patches falling off, or patches being boiled and injected. So it really just depends on the patient and how I choose to use it. Dilaudid, I like Dilaudid a lot. We have it PO, IV. Duration is 3 to 6 hours. It's a little bit more pricey. There's PCA, IR, and sustained release. I have been having luck with getting that sustained release Dilaudid covered. I don't know if you guys have started using that. It's generally the long-acting Dilaudid is generally not covered by most of hospice formularies. And I'm sorry, I just don't know about like VA formulary. I need to learn that a little bit more. But also in our, I take care of incarcerated patients as well, and it's not available for our incarcerated patients in DOC custody. So I'm always kind of aware of where the patients go in and who their major payers are. It's oral, sub-Q, IV. Usually those are the doses, kind of low dose, especially if they're more opioid naive, and of course higher doses for patients who have a tolerance. And we do a lot of Dilaudid PCAs here on the floor, especially for our traumas. And either I use morphine or Dilaudid to do a PCA on the drip for end of life care. Oxycodone is very popular. It's usually very accessible. I know a couple of months ago, we couldn't find Percocet anywhere, and we were rotating patients to straight oxycodone. But from what I understand now, I've not had an issue getting Percocet here in our area. It has a 1 to 1.4 ratio, a 1.5 ratio compared to oral morphine, lasts 4 to 6 hours. Typically, oxycodone is used when I'm starting someone out who's having an acute pain or cancer-related pain. It's generally pretty affordable. I am using long-acting oxycodone, Xtampza. I love it for my gynonc patients. Don't ask me why, but I've had great success using it for those patients. And I don't even have a very educated or clinical rationale of why it's working. But for that particular population, it has done really well. And also for my GI, my colorectal patients.
Cinnamon, that sounds like a good study. You can research it.
And you should be my co-author. We can do it together. It does come in IR and liquid, which is really good, especially that for liquid patients who have difficulty swallowing pills. Even though oxycodone's very small, it can be put in a peg tube, or it can be given sublingual. I know for a while oxycodone liquid was on national back order earlier, like at the end of last year, but now it seems to be pretty readily available, and most hospice formularies cover the oxycodone liquid. Those are kind of starting doses that are recommended, and then the sustained release, sustained release versions. And it's actually quite commonly dosed to like sustained release Dilaudid or sustained release morphine, and methadone. So just kind of just a poll, like how many of you are actually using methadone or initiating methadone in your patients, whether palliative care or hospice? I know, like I said earlier, I wasn't initiating methadone, but I have some patients where their OMEs are like 700s to 1,000s, and especially if they're having a lot of neuropathic pain. I've started becoming more versed in using methadone and titrating methadone. I've also developed a relationship with our methadone clinics here. So if it is a patient that I'm seeing in the hospital for acute pain and they're not appropriate for our outpatient clinic, I am getting them connected to a methadone clinic for continued management, especially if their insurance doesn't cover, or if I can't get them into a chronic pain provider. Most of my patients, just to be honest, are either Medicaid or unfunded, and we have very limited chronic pain providers in our area that accept Medicaid. So I don't know about other areas of Louisiana and Mississippi, how you're doing with getting patients, chronic pain patients, having them managed, but it's quite difficult here. Oftentimes, if I see somebody in the hospital and for pain, because we don't have an acute pain service, if I'm seeing them for pain, I am doing the work to connect them with a chronic pain provider. Let's see. Methadone comes in tablets and liquids. Like I said, I usually start to think about methadone if they're having a lot of neuropathic pain. It's cheaper than morphine. It's usually very readily available because other than like methadone clinics, not a lot of people like to use it. And it's not for short-term use. Head injury, and then we have to be cognizant of their QT. Generally, if their QT is greater than like 460, I would avoid initiating it, making sure they're hydrated, getting repeat EKGs just to make sure there's not any prolonged QT interval. I don't know about y'all, but the research I've done is like super, super mixed in regards to methadone and monitoring their QT intervals. Half the literature says that, to be cognizant of it and be cautious in titrating. And the other half of the literature says that it's a rare occurrence where you see prolonged QTs with methadone. I had a colleague who is from the East Coast. She says it must be a New Orleans thing because everybody has elevated QTs here as opposed to other parts of the country. I was born and raised here and only practiced here in Louisiana. So often I do encounter a lot of patients, especially on the acute hospital side where they have prolonged QTs. But that was interesting to talk to other providers from other areas of the country about QT intervals. Adjuvants. This is the fun part. And I guess that's kind of a dorky thing to say, but adjuvants are a part of that multimodal pain control. And let's just go from right to left. Analgesics, we have Tylenol, NSAIDs, ibuprofen, Celebrex, and Toradol. I love Toradol if the patient's kidney function is okay. I use it a lot of time if I have somebody that's in intractable amount of pain. I start with it IV and then I transition them to PO. Celebrex. I like Celebrex, honestly, for a lot of my patients, especially if they have bone pain. Of course, if I have to make sure that they don't have any heart issues. And of course, Celebrex has that black box warning and it kind of went into obscurity, but I have started using it. Medicaid must have thought I was crazy because they were denying it left and right. But I've kept pushing. Sometimes they recommend ibuprofen and they won't cover it. But it's on our 340B list here. So our patients can get it for about, I think it's like $17 for a month supply, something like that. In private insurance, I've had no issues with Celebrex as long as I add the diagnosis code. Of course, watch your renal function. If I have somebody who's on kind of severe, moderate, severe cancer-related pain, Generally, I have them on it scheduled. Sometimes I add a PPI if they're having GI issues. And also I watch it if they are on anticoagulants for whatever reason, for DVTs or strokes or AFib. Next, my SNRIs and SSRIs. I love these. Effexor, I'm generally doing it during the daytime. A lot of, I've seen from my renal cell cancer patients and prostate cancer patients who are on hormonal therapy for hot flashes and to help with sweating. Cymbalta, I like the duloxetine as well, 30 to 100, 120 milligrams a day, and usually I give it at night. Does cause some sweating, so I thought it was kind of funny. They do different things. Side effects you want to watch for hypertension, insomnia, drowsiness, dizziness, constipation, and dry mouth. Also, Paxil and Prozac. One place I found in the literature that actually boost the effects of TCA, so can keep that in mind. I do like TCAs actually, and use them a lot in my practice. Amitriptyline or nortriptyline. I usually start my little older people at 10 milligrams if they can tolerate it, and go up to 150, usually starting at very low. I like some of the side effects that it can. I use it for sleep and for weight gain. So don't be afraid of TCAs. I know there's like every drug has like a reaction, and they're telling you to watch for use of TCAs. But I'll run it through the drug checker just to make sure there's no interactions. But that has been great because it helps with sleep, it helps with pain, it helps with mood, it helps with weight gain. So that has been particularly useful for a lot of my advanced cancer pain patients. And then you have your anticonvulsants, gabapentin, good old gabapentin. I don't know, the research is mixed, and sometimes I feel like I'm over gabapentin and people are just on these doses and they're not even sure if it's even working anymore. I do find a lot of people come to me on gabapentin and they're still having pain, and it's just become generally sometimes I'll rotate them from gabapentin to Cymbalta. I am seeing patients on Cymbalta and gabapentin, and the literature is mixed. One's presynaptic, one's postsynaptic. I don't particularly see the benefit of using both of them. I know sometimes I do have patients who will come to me on both of those medications. Carbamazepine or Tegretol. I use this a lot for my head and neck cancer patients, and they've done really well on it. It does have a high side effect profile of somnolence and dizziness and things like that, and thrombocytopenia. I also found in the literature that carbamazepine works better for nerve pain related to the taxanes and to certain chemotherapy drugs. So I thought that was interesting. I've never used that as first-line treatment for neuropathic pain, often for refractory cancer, neuropathic pain related to cancers. But that can also be crushed and put into a peg tube. I've been able to find it occasionally in a liquid, especially for my head and neck cancer patients who may have difficulty swallowing pills. Watch for abuse, somnolence, and like I said, thrombocytopenia. I know in the Department of Corrections, they are using gabapentin. I know for our parish jails, they were not using gabapentin just because it had, just because of the abuse. Other things I use in kind of my multimodal pain is muscle relaxers. I love some muscle relaxers. Zyprexa, like I mentioned earlier, generally that one, you watch your QTC as well. I use that for sleep, pain, mood, agitation, also intractable nausea and vomiting. If they've been on Zofran scheduled and they're still having some nausea and vomiting, I'll use Zyprexa. If their QTC is elevated, I will also use low-dose benzodiazepines. Other things to help with pain management, psychotherapy. We're very blessed, and I say blessed to have a full-time therapist in our practice who sees our patients inpatient and outpatient. I almost think like if you're seeing palliative for symptom management, you need to have some psychotherapy as well. And we also have psychiatrists for oncology patients. So I'm a big proponent of psychotherapy just to help with the emotional aspects of advanced illness and management. Our practice does use medical marijuana. I, as a nurse practitioner, our institution hasn't given us the go-ahead to recommend medical marijuana, but we use it a lot in our practice. I don't know, have any other palliative medicine providers using medical marijuana?
We're not able to use it or recommend it at the VA either at this juncture, but I'm really hoping because I do prescribe a fair amount of dronabinol, and unfortunately, the manufacturers are really not making it. One manufacturer completely stopped making it like in January, February, where I was told yesterday that we're really not going to have access to it anymore, dronabinol. So I'm hoping that the VA will, change their tune in terms of the medical marijuana, but at this point, we're not able to recommend or prescribe it.
So, Robin, if a patient is let's just say they use marijuana at home, will you guys continue to provide pain management for them?
Absolutely. Absolutely. I think that's provider specific, but I can tell you all of the palliative providers will. Maybe not their PCPs, but if they're seeing us, absolutely.
Okay.
Our
Yeah.
providers and our nurse practitioners write for medical marijuana in our clinic. So
That's awesome, Mark. Yeah.
and
that's
as a matter of fact,
awesome.
that's a huge reason why patients with cancer pain are referred to our clinic to be able to access that. So
Yeah. What about home providers? Do I have any palliative home providers and they're using use of medical marijuana?
we have a home-based palliative care nurse practitioner in Baton Rouge who does that.
Awesome.
I'm a home provider over in Biloxi, Mississippi, and I can't prescribe it unless my collaborating physician does, and he currently does not. But we will still provide pain management for our patients who do have medical marijuana through like a different pain management clinic.
Yeah.
There's a couple palliative programs here on the coast that will not. And so we've actually gotten quite a few patients transfer over to us since we will let them stay on their marijuana under palliative.
That's awesome. Tell me your name.
It's Addie Walters.
We see a lot of patients from Mississippi. So please take my information down or put your information in the chat. So if I have somebody from Mississippi, I can connect them with you to send them home. And that's another thing. I'm just going to step aside and just give a huge shout out to them LMHPCO, because platforms like this allow us to meet other providers in different areas. And we at UMC get patients, and I'm sure at the VA get patients from all over. And I would like them to be able to see somebody in their home areas. So yeah, please send me your information so I can connect my patients with you that go back to your area. And thank you for that. Also, to be honest, medical marijuana is expensive. And so some of my patients are spending like $300 a month. And then some of my patients simply cannot afford that. And so they get street marijuana, which we have extensive discussion about that. And we have a huge issue here in the New Orleans area with marijuana being dirty. And so I have to make sure I counsel my patients on ensuring their suppliers and where they're getting it from. Some of my patients have switched to getting it from not, I don't want to say, and maybe this is off the record, from dispensaries in other areas that are a little bit cheaper, but it is very expensive. And if you're on a fixed income, medical marijuana is just maybe out of reach. I will say I have one patient who has been on medical marijuana. He has lung cancer with brain mets, and he is not on any opioids whatsoever. He just does his medical marijuana. So I have seen patients get off of everything completely and just use their marijuana, and it has worked great. I've had one patient that had vomiting related to the marijuana use, but that's one. And when he stopped the marijuana, the vomiting went away. So that's the only issue that I've had, other than marijuana being street marijuana being dirty. Also, PTOT, acupuncture. Our patients in our hospital system have access to PTOT here, and there's an acupuncturist here. But that has done great for a lot of patients, especially if they have neuropathic pain. Complementary medicine. Patients are always coming to me with what they found on TikTok. I don't know, I'm not a TikToker, and I don't really know what's out there, but they're always coming with the latest thing on some like cancer treatment. And I'm the last person to say no. Sometimes if they can come, bring it to me and I'll research it, and I'll talk to pharmacy and I'll talk to their oncologist. And my rule is we do one thing at a time. So if you found something on TikTok that you like and you can bring it to me, it's just introducing new things, not introducing a bunch of new things, and just being consistent. But I am very open, and I find that by me being open to patients wanting to use complementary medicine, that they've become more engaged. I've even had some patients who the biggest thing that I get is soursop. And I guess that's trending on TikTok now for cancer patients. And so patients are like really interested in using it. I only have one patient that grows his own and boils his own. And he has two primary cancers. He has prostate cancer and he has CLL, and he's doing well. But part of that is just that, and I always advocate, I want you to do those things, those other things. If you think this soursop is going to work, how about we do your cancer related treatment and we do the soursop and go down the road with that, versus being opposed to it because I don't know exactly what it is. Like I had a patient the other day who says they're doing like coconut soup. That's natural. I don't really know of why it would be contraindicated, but they were just glad that I said, okay, keep doing it. You're hydrated, your labs look good. Keep doing what you're doing. Just stick with one thing at a time and just be consistent when it comes to complementary things or things that are being advertised. I also use a lot of lidocaine and capsaicin, and also the integration of nerve blocks. So those are generally covered by insurance, and so they have done great for a lot of head and neck cancers, pancreatic cancers, and gynecological and colorectal. So also use those things. You have those in your arsenal to help patients, and And it just doesn't need to be about opioids. I have patients who actually say they don't want to be on opioids at all. So, and that's fine. And we just walk down the road together and use different things to help with pain management. All right. I know my time is getting short, but it's kind of like, what are the steps that you go through to help, understanding and picking a medication? And this is kind of a little diagram that I use to kind of help me in my decision making when I'm choosing drugs for pain management and how to move forward. Medical mistrust is huge. So a lot of that is because if your patients don't trust you or believe in you, they're not going to do anything you say, especially when it comes to adjuvants. They know about oxycodone, morphine, and Dilaudid, but they don't know about that Elavil. So if they don't know what Elavil is or why I'm ordering it, they're not going to take it. So it's just establishing that trust goes a long way. We've got a few more seconds. Case study number 2. Patient AD is a 64-year-old African-American woman with a past medical history of pancreatic cancer, currently on chemotherapy, has Crohn's disease, prior DVT, who presented with worsening abdominal pain for 2 weeks. Those are her vitals. In the ED, she got a liter of fluids, some antibiotics, Dilaudid and oxycodone. You see her labs here, her physical exam. Kind of share your thoughts on what you would do for this little lady.
I want to refer her for a celiac plexus block.
Absolutely. I'm so glad you said that out the gate. Yes, yeah. Absolutely. I'm telling you, that has been amazing for our pancreatic cancer patients. So if you haven't been referring your patients to IR, or if you don't have a place to refer your patients, refer them here. I always am blowing up IR's phone. When I call them, they're like, okay, what do you need now? And I was like, well, this is what I'm thinking. And so I've had good results, especially with pancreatic cancer, kind of mixed for head, neck, and gynec, but yes, absolutely. I'm glad you said that. Anybody else or any other thoughts? So essentially, this is what I did for her. She got some Zyprexa, continue IV fluids. She started her on a fentanyl patch because she had difficulty swallowing. Continue IV Dilaudid, and then kind of wean that off. And then if we can wean down or convert to PO, we do that as soon as we can. But essentially, that was my initial plan for that patient. There's some of my references. There's my phone number. Addie, please email me. Thank you guys for your time. Sorry it was so fast and short and sweet, but thank you also to the palliative care group that invited me to speak to you guys. I'll hang around if you guys have any other questions or thoughts.
Cinnamon, thank you. That was excellent.
Thank you, Cinnamon.
Thank you, Cinnamon. I enjoyed listening to you as well. Always.
Thank you.
I'm going to send, I copied the questions in the chat box and I'm going to send them to you.
Perfect. And I will make sure to respond to each one. Also, if you guys, before you log off, if you just want to put where you are and where you're from and a contact number. So maybe if we have a patient going to that area, we can have connections in other areas. It's always great to meet people outside of the New Orleans area.
I just want to let everyone know the slide deck that you sent me, I have put in the calendar invite for today. So everyone who has that calendar invite, you should see the slides that Cinnamon has used today, the PowerPoint. And if you don't see it, let me know and I'll send it to you. Thank you.
Thank you,
Hello,
Cinnamon.
Ms. Cinnamon. We have a question.
Yes, sir.
We want to know this. Sorry, this is Kathy. We're from St. Tammany Palliative Care Group. Just had a question about how are you using Zyprexa for pain?
Sure. So generally, if somebody's having a lot of some neuropathic pain, they may have some lots of anxiety. I will generally start, or in particularly nausea, I'll generally start it at night orally. If they're here in the hospital, I will do it IV. And it helps dramatically. It also helps with them gaining weight, and increasing the appetite, and also helping with sleep.
So you're using it, you said, mostly for nerve pain?
Yes, ma'am.
One little add I want to put in there, as far as the hot flashes, there's been some research that shows for hot flashes at night, gabapentin. I've used that, and I've even used it with some of like prostate cancer patients, with the men, and it's worked really well.
What dose do you normally start that at?
I just did 300 milligrams QHS.
Yeah, I do the same thing. I agree with that. I use gabapentin for that as well. I prefer the duloxetine for like the neuropathy as opposed to gabapentin, but as long as it's a patient that I know is going to be pretty compliant, because if you stop the Cymbalta abruptly, that dizziness gets out of control. So you have to wean duloxetine, I find, especially if you're on more than 30 milligrams a day. You kind of have to wean them down because they will get super, super dizzy.
Do you? I'm one of the things with gabapentin. For the most part, is pretty regularly available. I also use it for my liver patients, and monitoring those doses. And I also sometimes have to remember also that sometimes we need to wean back some of these medicines, especially as their functional status declines. So I just always want to make sure that when I'm talking to nurses, remember that we can go backwards too. You know, we may have to, like, if they're having a lot of things going on, and if they come into you with like a grocery bag full of medicines, it's like, wait a minute, like sometimes de-prescribing actually helps as well. And one of the things I forgot to say was like constipation. Like I find a lot of times we're chasing things and the patient is actually constipated. So that's one of the things I never want, especially with our residents here, is forgetting to monitor patients' constipation.
Hey, one more question. What code are you using for Celebrex to get it approved?
So I'll have to send you. Usually I put that, is it Z51.2 is palliative?
Okay, just pass the can counter.
Yeah. Uh-huh. I'll add that, and I'll get it approved. Sometimes I find like when we send out the prior authorization, and sometimes they'll make me do a peer-to-peer. And I don't want us to be afraid to do a peer-to-peer. Every time I've had to do a peer-to-peer for drug management, I've always gotten it approved. And I was like, well, damn, that was quick. Usually you spend more time on hold waiting to even get to speak to a human. And they've gone through, usually it's just a generated automatic denial. But when I explain what I'm using it for, I've gotten it approved.
Okay, thank you.
I'm having that same issue over here in Mississippi with even Zyprexa getting it approved, and they've been denying my PAs and everything. But I am also finding that if I have my patients use like a smaller mom and pop pharmacy rather than Walgreens or Walmart, for some reason the mom and pop pharmacies are pushing it right through.
Oh, wow.
Even though it's the same insurance company. Yeah.
And even with the diagnosis code attached, they're denying it?
Yeah, Walgreens and I get in frequent arguments because Walgreens pharmacists, even if insurance approves it and I have everything coded and appropriately, the pharmacists are telling me, no, that's you can't do that. You can't prescribe even like Norco 10s 3 times a day. They're giving me feed. Like it's gotten really crazy.
Walgreens is the worst. I agree. Even here in New Orleans, I have trouble with Walgreens too, just outside of the the VA, and I have much better luck with the small mom and pops too when it comes to stuff like that.
Absolutely.
Now, are y'all having issues? And I've had some issues here with if a patient is going to a nursing home, they want me to stop methadone or they want me to stop the Zyprexa. I've had to have a couple of firm conversations about that. One absolute nursing home said absolutely not. And this was the last place that I could get this patient approved. So I had to deprescribe it and switch it. But I find there's a lot of pushback. Like if they don't have that psychiatric diagnosis in the nursing home, they won't let them go there with a medication like that.
Yeah, the nursing homes are in a tough spot because they're being audited, right, for their medication use, and antipsychotics is like number one on the list that surveyors and they don't want to see those patients on antipsychotics because it's considered like a chemical restraint. But it's hard because we use it for so many different indications. We're typically a lot of times not using it for psychotic reasons in palliative care. So it's a huge challenge. We've had to do that too. We've had to deprescribe things just like quetiapine. They don't want to take patients, on quetiapine sometimes. I find that if they're on hospice care, it's a little bit different. If they're going to the nursing home with hospice, then it's a lot easier to get those things, kind of through. But if they're just palliative and they're not yet hospice care, it's a lot harder to get the nursing homes to accept those regimens. Yeah.
Right. Now, are you guys from the hospital? One other thing that I've seen was patients going to like a sniff or an LTAC with methadone. Often I'm having to give them paper scripts. Are you guys having to do that?
We've had to from the VA even. Yes, we've had to send paper scripts for any opioids really that we're prescribing. Yes.
Yeah, I'm definitely working very closely with case management because I don't want the patient to fall off. I've actually had a patient go to a sniff and then the sniff sent them right back here. I guess they didn't catch the fact that the patient was on methadone, which their clinical people were supposed to review it. But also communicating that, hey, this is what this patient is on, why this patient is on it. I think until there's further education from those, on the state level and who are reviewing in the nursing home administration, I think we're going to have to continue to contend with that.
Yeah, and as providers prescribing these medicines, it's almost like we have to find out first, okay, where do you live? What's your living situation? Are we going to a nursing home? And before prescribing, right, switching regimens or deciding on a regimen, finding out if it's going to be okay with wherever they're going to be staying, which is really just another barrier to providing good pain management and symptom management.
Absolutely. Well, thank you guys for your participation. I hope one day to see everybody at conference and get to meet you guys. But please continue to share your thoughts, grow palliative medicine, and thank you what you're doing for our patients every day. Bye.
Bye.